Okay, everybody. Thanks for joining. I went ahead and started recording. So if you don't want to be recorded, have your slate up. If you're cool with being recorded, then let's see your pretty faces. So here we have. So we're going to talk about preventing and responding suicide in LGBTQ plus communities. And we have Bradley Lake here, who's from the Implicit Bias Institute. He's going to talk about an overview of suicide. He's going to kind of give us an overview of the issues, right? And talk to us about some of the work he's done with the Implicit Bias Institute, especially regarding colleges in this issue. And then Lucia is going to talk to us about what we need to know when we're working with transgendered individuals in relation to suicide. It's also going to talk about, Lucia is also going to talk about harms done to trans communities by helping professions. You know, it's a lot to know, and he's gonna, they.
He and they pronouns are awesome.
Which pronoun?
He and they pronoun. He and they pronouns.
He and
either
they.
one.
Okay, all right, and that's something I am trying to learn too. So thank you for that. So they're going to tell us about trans communities and the helping professions, and then situations that increase the likelihood of suicidal ideation and suicide attempts and completions in trans communities. And then third, we have Janae Holland, and she's from the Comfy Place in Georgia. She will be joining us shortly. She's going to talk about things we need to know about working with individuals in LGBTQ communities, some clinical knowledge. She's also going to talk about body language and how important that is. And then we have Erin Hill from Erin Wyndham-Hill from UGA's. What is remind me of the name of the center, Heatherly? My brain is just all over the place.
Yeah, that's what I'm trying to remember.
It's our own UGA center, and
it's not the comfy place. No. Aspire. No. I have no answer for you at this moment.
Forgive me. I have no excuse. Okay, so now we will go and we'll have Bradley take it away.
Okay, thank you all for inviting me. I'm happy to be with you all. I will try to speak somewhat quickly because you've got some great speakers. I'm really interested in hearing what they all have to say. So I'll try to cover a fair amount. So I actually am in outside of Annapolis. And so I'm a distance from you all right now, but I co-created an organization called the Implicit Bias Institute with a woman named Dr. Kavitha Avula. And we go around to different organizations and have done a lot of work with colleges and universities around doing pretty intensive awareness about issues of implicit bias and its impact on students, its impact on faculty, its impact on administration. One area has been in the LGBTQIA plus communities. I'm also a clinical social worker who's been in private practice for 35 years. So then I started the first gay and lesbian psychotherapy group at the University of Maryland during my internship about 37 years ago. Those groups still exist. And sadly, I did get death threats when I created it as a student all those years ago. But they have withstood the time and the resistance, and to the best of my knowledge, they are flourishing. One of the things that I think is kind of really important and is always evolving right now is in the acronyms, it's important to be honoring who we are. And so defining yourself as an integral component of how we are perceived and how we present ourselves to the world. I think a human condition that we all want is to feel seen and heard. Members of the queer community have fought for decades just to have a seat at the table, and now have another debate has come to the forefront in recent years as the QIA members seek to be represented in a more dynamic and direct way. So it's important, just as it is important to better understand pronouns and how it's used, and My husband and I have 2 kids. They're both adopted. They're both of color. I just got off the phone literally before this at a very progressive school where my daughter is, where one teacher keeps on, because my daughter identifies as a tomboy, as a lesbian, as she and her. And the teacher keeps on referring to her as they. And it is very hurtful, and it is not stopping. And either education has to happen or she needs to be with a different teacher. And I'm very clear about that. So this is important. And so I think for most people, we know what this means, but I'll just say it. The L is lesbians, gay is gay men, B is bisexual, T is trans and transgender people. Feel they are not gender. They were not gender that they were assigned at birth. And I'm so looking forward to hearing, Lucia, what you have to say, because this is a population, in my opinion and in my practice, that currently are targeted right now in the biggest possible way and are holding and carrying so much pain. Q stands for queer, for everyone under the LGBT plus umbrella, and stands for queer or questioning. This is a controversial letter as some prefer it, while others use it with caution. Questioning people are still exploring their gender identities, gender expression, or sexual orientation. I is intersex people are those born with reproductive or sexual anatomy and or chromosome patterns that isn't firmly male or female. A represents both allies and asexuals. Allies are straight and cisgendered people that support the community. Asexuals are people that do not experience sexual attraction to anyone or low levels of sexual attraction. And then the plus has been used in many circles to stand for all other identities after the LGBT initials. So let's go more directly to the issue of suicide. So Dr. Anitha Iyer, Chief Clinical Officer and Vice President of the Vibrant Emotional Health, the organization that runs the National Suicide Prevention Lifeline, emphasizes that the most important step is creating spaces and opportunities for students and colleges to connect with one another. In order to engage students and parents in an ongoing and active dialogue around mental health before they have stepped from one campus their freshman year. In a moment, I'm going to give you a case study real quickly that is literally just unfolding in my private practice. A statistic that feels important to know is that 2 in 5 LGBTQ youth in the United States, this is a report that came out in July, have seriously considered showing what one expert called devastating mental health consequences of society's failure to create a safer and more affirming environment for America's queer youth. And that population is kind of broad in these statistics, which is that the survey found that 40,000 LGBTQ people were given a questionnaire between the ages of 13 and 24. So we now are, that is inclusive of the college age students, and found that 68, almost 70% of the respondents reported symptoms of generalized anxiety disorder, 55% reported symptoms of major depressive disorder, 48% reported engaging in self-harm. In addition, 40% say they have seriously considered attempting suicide in the past year. These are big numbers. I want to step in because I really just want to honor other people's time to speak. I wanted to step into this case example, and as I say that, I just want to honor something that for me as a clinician feels so deeply important as I go through this case. In my opinion, there is a big subset between the developmental arc of a young adult and dealing with and coming out as LGBTQ+, as they are also trying to step into areas of differentiation and separation. So if you think about it, the college students are really trying to step just more naturally into a place of who am I? How do I separate and differentiate from my places with my family and my family of origin? And at the same time, they're stepping into deeper issues around identity. And the identity issues can also often come with an enormous amount of shame and or guilt. And it is in a mental health sort of perspective, it can inform an enormous amount of instability, an enormous amount of uncertainty, and a lot of fear. So, there's no longer are these more easily quiet places of I am different than you or you or you or you. When they were younger, it is so much coming at them at the same time. The case study is that I am working with a young gay man who identifies as Asian and was adopted and is a freshman in a college. And I have been working with him since he was 13. He is now 17. He is grown an enormous amount. He has grown in his capacity to be able to express what he feels, who he is, and has really stepped into young adulthoodness, if you will, I think, in a very meaningful way. He has a roommate who has attempted suicide recently, who identifies as straight. The safety component of the school has now asked him to track his roommate daily as to his safety. This is quite a substantial university with, a lot of resources. It's a private institution and has supposedly a strong counseling center. As this has been unfolding, I am increasingly concerned. I'm experiencing my client as feeling more and more overwhelmed and burdened. And very clear, this is not his responsibility. In our last session, literally 2 nights ago, I can see the distress coming on more strongly. And then yesterday, 2 days ago, he turned 18. That becomes a trickier issue, which is, how do you feel if I reach out to the school? How do you feel if your parents reach out to the school? You're no longer a minor now. What do we do? Please don't reach out. My parents are going to make it too much of a big deal. He was able to make some movement. I quickly set up a session with his parents and him yesterday. The parents reached out to the school, and this morning, the mother and I had a conversation on the phone, and the response was, Bradley, you can't believe this is like so up your alley. It's like nobody's business. I literally heard, because he's a straight A student, because he's well-mannered, because he's Asian, and because he does not seem to be having a romantic relationship, he's well-equipped to be doing this, to be looking after his roommate and making sure that he's safe. There is so much bias in this, clearly and blatantly. And clearly, this is not a useful situation for my client and this student to be in. And now going to get quite active in changing this dynamic. But the way that faculty, the way that other students, the way that counseling departments are aware of their own of bias are extraordinarily important in the reduction of suicide and suicidal ideation for the LGBTQ community students. Just to state it once more clearly, implicit bias is an umbrella term for the attitudes, beliefs, and stereotypes all carry, myself included. It is a key component of the brain's architecture. It is part of how our mind collects reasons and stores data about the world. It is a neurological phenomenon. Therefore, it exists for all of us. And unless we actually step into the reality that we all possess it, then we can't bring about change. And if we do, and the type of work that Kavitha and I do in universities is we do a lot of experiential, a lot of role playing, a lot of group work to sort of bring about greater awareness. And what we have seen as we've done this work in different universities is we've actually seen the rates of suicide and suicide ideation go down. There's a direct correlation. We're now mapping it now that we've done this for a number of years, like 3 or 4 years in different schools. So I'm going to hand it off. I feel like I talked too much already. And thank you for your time, and thank you for the work that all of you are doing. Appreciate
Thank
it.
you. Thank you, Bradley. So what we'll do is we'll move on to Lucia, and then if our next speaker, Janae, is not there, we'll go on to Erin, and then we'll open it up for questions. And I know I have some questions already, so I'm sure other people do too. So, and now we're gonna have Lucia take it away.
You bet. So, as a clinician who is non-binary and trans, I work almost exclusively with individuals from within my own community, the trans community. And I would say right now, around half of my caseload is adolescents from about middle school age up through university age. So the study that Bradley was talking about, wherein like the 68% like reported generalized anxiety, non-suicidal self-harm, suicidal ideation, I see a lot of that. And so a lot of the factors that ameliorate some of those concerns are, first and foremost, like having an accepting family unit, the immediate family unit, the place that the kid goes home to. That already is the biggest factor between a kid thinking about or attempting suicide, which for trans youth is 1 in 3. Typically, like, unfortunately, when there's not an accepting family unit, that then leads to that greater likelihood of attempting suicide. And so first and foremost, the accepting family unit, like that's a lot of the work that I do, is making sure that parents have a place that they can go for guidance, because they have questions about hormone transitions, social transitions. Sometimes they don't know the difference between different types of transition or how to best support their kiddo. So that's a lot of the work that I do on the front end when I start working with a kiddo. And then on the back end, I usually have colleagues that I can refer out to whose specialty is working with parents of trans kiddos. The other factors that help to ameliorate suicide or anything else really, like substance abuse, eating disorders, these ineffective coping skills that we see our clients reach for. Homelessness and houselessness is a huge issue for our community, especially for trans people of color, which is why organizations like the Trans Housing Coalition in Atlanta is so important. The next thing is access to cost-effective medical care, because there are places like North Druid Primary Care that can do some sliding scale services that do provide primary care to trans femme individuals and some trans masc individuals. We have our own Queer Med here in Atlanta, and they provide services out of pocket and telemed services to help connect people with hormone therapy, and they're an informed consent location. So for the adults that I refer to them, they don't require a letter. The letter writing, which is a big thing for trans folks trying to access gender affirming medical care, is such a huge barrier. I see folks charge 50, 100, 120 for a letter that it takes 10, maybe 15 minutes to write. That's an exorbitant barrier for my community, which is why I do it for free. The Gender Affirming Letter Access Program, GALLOP for short, is a national project. It's a collaboration of providers who will provide these letters for free. So as a part of that project, anyone that approaches me and they're like, hey, I need a letter. Do I need to be in therapy? Do I need to pay for it? I'm like, no, I just need to consent for it, and I need to know where and who to send it to. Because access to that transitional medical care, it is paramount, not just for mental health, which is all well and good, but also for life-saving measures. Some people are suicidal because the sense of living in a body that doesn't feel like home is so distressing for some folks. And so the ability to access hormones, surgery, these other services that we desperately need is so important. So housing, medical care, mental health care that is cost effective, housing, accepting family members, like that is a large reason that I do. Part of my practice is sliding scale services, free letter writing services. And also I do support groups for masculine of center trans folks, masculine or feminine and masculine groups. So for trans folks, any non-cis individual who has a feminine of center identity or masculine of center I have an adolescence group, which is for those who are 14 to, right now my oldest is 16 in that group. And then I also have my annual transfer the holidays group, because the holidays are jam-packed, with just tons and tons of amazing baggage, let me tell you. So I do my transfer for the holidays group as like a standalone group. And it tries to, in as many ways as, mental health provider can do, provide that emotional padding or insulation or reprieve, if you will, when having to deal with friends, family, coming out, not coming out. And for a lot of my clients that choose not to come out, it's because they want one more Christmas or one more Hanukkah with their family, because they know their family's going to cut them off and they want that sense of closure. Like, that lack of closure can be, getting that closure can be so important, and weighing, do I be authentic or do I get this closure? Like, that's not a dilemma any human should have to deal with. And moving through that space is very important. Access to food, access to medicine, not just hormones, but mental health medication, access to competent care. I cannot tell you the number of times that if I go into a practice, a medical practice, mental health practice, up until about 3 years ago, when I started seeing an improvement, I was the point of education for all of my providers. And when I know more about my HRT, my hormone replacement therapy, than the endocrinologist prescribing it to me, that's kind of a problem. I've also been hit with, in primary care settings, oh, you might want a different doctor. I see normal people, right? So these things that, despite being in 2021 and coming up on 2022, we still experience these barriers, even when medical care is accessible through health insurance. That doesn't mean that the providers are competent. There's a great conference that happens every year. It's the, what is that? Conference on excellence in transgender healthcare. That I recommend that for all medical and mental health providers. And also there is, there's so many different resources for my adults that need accessible, like sliding scale care, or they need to be able to access hormone therapy. Plume is a great resource. Plume, spelled like the feather, Plume, is a telemed service, and it provides as few barriers as possible. So for like $100 a month, that is what I pay to get my hormones, and that covers my blood work, which I then pay, $15 every couple months for my testosterone. That is an accessible service, and they have a scholarship for Black and brown trans folks who wouldn't be able to otherwise access it. There is a fund from out in the West Coast, and I forget the name of it, but they also do scholarships for hormone therapy. And this is something that we're seeing more of, because without these services, our community members aren't very likely to reach middle adulthood, let alone young adulthood, which is highly unfortunate. So that's like a quick précis about the barriers that face our community. And then the other part, which I'm really happy we're holding space for, is acknowledging the harm done by the helping professions to this community, because it's very important to understand our bodies and our identities have been pathologized. It was only the 70s when someone who was gay was no longer, diagnosed for being just gay. And there's another movement in the endocrinology community that would help to make gender dysphoria as a mental health diagnosis obsolete, and therefore the requirement of mental health letters obsolete. And the endocrinology community would then have an ICD code of, hormone imbalance related to gender identity that would make it a singularly medical dilemma, not a mental health dilemma. So then we could still offer support, but not have to pathologize people or expect them to have to explain their history over and over and over again, which is at best highly invasive and like dehumanizing for some, unfortunately, based on the systems. And in our field, in social work, which I did graduate from UGA with my MSW, and I had such an amazing experience. And I was blessed to have professors that could use my pronouns correctly or knew to ask for my pronouns, that did allow me to teach certain portions of the courses based on gender and sexual identity, because they would hold a space for me that allowed for me to deliver that information. And unfortunately, that's not the case for everyone. there are sometimes issues or concerns with, how to say it politely, some supervision sites which hold very strong biases, places where I have worked but not been an intern, where I on paper was fired for different reasons, but it only happened after I was outed by a client as being trans. So we can already tell where, what likely was the case here in the Southeast. And so, and even in that space where, by the way, I loved the job, I loved the work that I did, I saw a lot of harm done. I was expected to keep quiet. I was told it was highly unprofessional to come out as queer or trans, because why would my clients ever need to know that if I'm a competent provider? So being told as a professional that I need to stay in the closet and then modeling that for my clients, right? That's highly detrimental. It's very stigmatizing for folks who are queer and trying to get eating disorder care, substance abuse care, which already highly problematic for folks who are queer and in substance abuse recovery, which has a lot of religious talk about it, is already very alienating to queer and trans folks. So when this discussion started a couple months ago, and I saw on Instagram and Facebook, like, people were not too happy to hear that someone wanted to have a town hall about their history of harm done in our profession, a lot of people got very strong feelings, which is very respectable, and I validate that. And if we don't hold space for this and what our field has done wrong, we A, cannot accept it, and then B, move on from it in a way that allows us to grow as helpers in order to meet the community where they're at, whether that's gay, lesbian, trans, wherever. That is just, I'm handing it back over to our next speaker.
Thank you, Lucia. That was really educational for me. That and I really appreciate you coming and telling us. And I think one of the things that those of us in the helping profession need to, and I hope that I can do this as after I graduate and mature in my career, is always be willing to learn and always be willing to question our own beliefs. Even if we learned 5 years ago that something was the way things were done, we have to be willing to update that knowledge as things change and we get new information. So I think that's amazing. So now we're going to pass it on to Erin Wyndham-Hill from the Pride Center at UGA. Take it away, Erin. Thanks for coming.
Hello. Sorry for the lateness. I had a student emergency like I do all the time, but that's okay. My name is Erin Wyndham-Hill. I use all of the pronouns, and I am the senior coordinator at the UGA Pride Center. So I'm going to talk a little bit about, I know a lot of you might be not on campus or sort of on campus, but we're still all in the UGA sphere. So I'm going to talk a little bit about what we experience in terms of our students and their mental health needs, and then some other stuff. But yeah, so if you have any questions at any point, feel free to stop me. But I guess the biggest thing that we are seeing with students is that more so than I thought, students in the LGBT community and particularly the trans community here at Athens feel like UGA is actually a really accepting space, which is something that was a little bit surprising to me, but very good to hear. I mean, that doesn't mean that we're without incidences of homophobia and transphobia on campus, but it is a lot less prevalent than I thought it would be. So that's awesome.
I mean, caveat there, I went to the Duluth campus, so take that with a grain of salt.
Yes, there's that. In terms of the undergrad experience on the Athens campus, it is better than I thought it would be. But things still happen. But I would say the biggest things that students struggle with on this campus are knowing exactly where it is that they can be out, because students do still come in with the perception, like I did, that we're in Athens and it's probably not going to be as accepting as you would want it to be. And it is a little bit more so than students would see, but that still doesn't mean that they're going to want to walk into a space and be out immediately. So finding spaces where they can come in. A lot of students are coming from families that are not very accepting, because we are still in the deep, deep South and in the United States. I mean, go find it anywhere. But so we have students that are coming in and wanting to explore their identities, but might not be ready to walk through our doors to get to our office. It's right in the middle of campus. We have Progress Pride flag outside and a trans flag outside, and it's pretty clear where you're going when you're coming into our office. So students don't always want to do that immediately, which we totally get. And we will go out and meet students. I've met students around campus, around Athens, just to be like, you need to talk to somebody, but you don't want to come through our door. That's fine. It doesn't mean you can't access our services. So we have that going on. So our center, being a campus with 56,000 students, our center has 3 full-time employees. So reaching everyone is really difficult. Everyone knowing that we exist or what we do is difficult. So trying to leverage our relationships with campus liaisons and stuff like that is, that's our biggest goal right now, is to just have every student know that we exist, whether or not they actually utilize our services. To know that we're here means a lot to a lot of people. So besides just knowing where we are and feeling comfortable enough to access us, the stuff that we're seeing with our queer students is that campus services don't always work the way that we want them to, or they are told that they work. So especially with students who are looking to change their display names on things, they are supposed to be able to fill out one form that goes through the registrar's office that will change their name on ELC, on Outlook, in their advising software and stuff like that, but that's not always the case. So we get a lot of students coming in saying, I submitted this form, but I still see my dead name everywhere, which is bad. Or I'm still getting called my dead name in class, which is very bad. So I would say probably multiple times a week. It's really easy to actually get it fixed. It's just it's a help desk email to say like, hey, my display name needs to be this. Can you fix that? And IT will say, absolutely, yes, they'll fix it within the hour. But the fact that students fill out the form and it doesn't work the way it's supposed to is just another step that students have to go through to be reminded that there's all these hoops that they have to jump through to be recognized as who they are on campus. We are getting better about that, though. Those processes are getting better. We just made it, we worked with the card office to make it so that students can have the names that they actually use on the front of their cards now. It's not perfect because they're still technically legal documents. The legal name is on the back of it really small, which is not great, but it's at least better than that being the first name that you see up on the front. And we are in the process of trying to get students to be able to put the name that they actually use on their diplomas. Because right now diplomas are considered to be legal documents, which is weird because I have never been asked for my diploma to prove who I am before. And the feeling of being given your diploma for graduating college with a name on it that you do not use has to be awful, right? And it just has to be another reminder of everything that you have had to go through on this campus to be recognized as who you are. So also, you know, in my office, I have my diplomas up on the wall, but if I had a dead name, I wouldn't put those up there. And so like, that's just another thing that our students are being deprived of because they can't have their actual names they actually use on their diploma sometimes. So those are big issues that we deal with a lot that we're really trying to work on. But in good news, there are other things. We do have a lot of really good services that students have access to. So students can access HRT at the health center, which is really awesome. Hormone replacement therapy. Yes, thank you, Lucia. Yes, they can access hormone replacement therapy at the health center, and the doctor there is awesome, and I have only heard good things from students. So that is a really, really good thing. Students can also access PrEP at the health center, which is very cool. Yeah, so those things are really good. And we have a great way on campus of essentially if a student comes to us with a problem, our director Chad and I will be on the phone until the problem is solved and the student has an apology in their inbox. So it's not to say that students don't face discrimination issues on our campus, but I think that we're taking all of the steps that we can to decrease those instances. And if we ever find out about them, we're not leaving until it is addressed. So I think our students know that they're in a place where they will be fought for if that needs to happen. But we do often have students coming in, especially within our community. Here, students might feel very supported, but if they have to go home, say for the holidays, or because campus shuts down because there's a global pandemic, that can create an additional barrier to accessing our services because students might not be able to come to our online programming or our online support groups or stuff like that, because they might have to log in on a computer where their dad might show up behind them or something like that. So we've had to think of creative ways to sort of have other offices promote what we do sometimes, just to try to find ways for students to still access our services, even if it's not the best location for them to do that. Typically when I have students struggling the most with their mental health and situations of suicidal ideation are issues where it's not the campus that they don't feel supported at, but it's at home. Or they told their parents that they're trans and now they're cut off. Or they told their parents that they intend to have top surgery and they no longer have access to their parents' insurance. Things like that. And we do have ways of helping those students. Like I will work with other offices. We did find another way for a student to get insurance that will cover their top surgery. But it sucks that they had to go through it to start with. So that's a lot of the stuff that we see on our campus. It's less of UGA is not an accepting place and more of there are all these factors in the rest of my life that are still affecting my mental health that I need help with. And then switching a little bit, we get a lot of questions from students when we do trainings. We do a couple different things. So we have our Dog Ally program, which is what Safe Space used to be. We changed the name because you can't guarantee that somebody creates a safe space just because they went to a training. So Dog Ally we do, which is a more involved training. It will now be, it should be like a hard launch in January and a soft launch in the next couple of weeks. So if you want to do the Dog Ally training, feel free to email me and we'll get you set up with that. It is now a 7-part animated online module. And the only reason it's not hard launch right now is because all of the voices are me and we're getting students to record the voices as voice actors. So it's not all just me. So it's that 7-part training and then a 1-hour debrief session. So it's a lot easier to access than our 4-hour lecture that it used to be. So we do that and we do an LGBT one-on-one or 101 for students where we're essentially just brought into classes to do panels. And the questions that we get most often with those are just like, how do I be a better ally to students? And what we say essentially is like, it's really not that hard. Use the name that students use. Use the pronouns that students use. Those two things decrease suicide ideation so much. It's like 67%. Lucia, you probably have a better number for me, but it is so easy to support people by just using their name and their pronouns, and that is not hard. And something I say to people, because it often scares people, like, okay, you tell me that I need to use somebody's correct name and somebody's correct pronouns, and I think that that is so important that I'm going to not use any name or any pronouns for them because I'm terrified to get it wrong, and then that person will hate me. And everything will be bad after that. So what I tell people as well is it's okay to mess up sometimes. We all mess up sometimes. I misgender myself all the time because I was raised for 23 years thinking that I was a straight woman, and it turns out that was very false. But that doesn't mean that I don't have those things in my brain still. So people mess up and it's okay as long as you are trying to correct it and you get it right the next time. So if you misgender somebody, say, oh, I'm sorry, and then restate it with the correct name, the correct pronouns, whatever it was that you messed up. And then later you can apologize to that person one-on-one, but as long as you address it and you get it right, you can move on. It's not the end of the world. And people will appreciate you for having done that and for having made a point to use their correct name and their correct pronouns. So that's honestly the question I get the most often from people who say, how can I be a better ally and what do I do if I mess up? And I think it's a lot easier than a lot of people think they will. So as we do this work, we will mess up, and it's okay as long as you fix it and as long as you make a conscious effort to not do it again. And then the other thing that I think in terms of the age group that I work with, this does happen a lot at, yes, also ask what is your name and what are your pronouns. I like to introduce myself. My name's Erin Wyndham-Hill. I use all pronouns. What is your name and what pronouns do you use? But I will add to that, if you're in a space with other people, don't ever require anybody to tell you their pronouns. I've been outed at work, not in this job. In this job, I'm fully out, but at other jobs that I've had before, I've been outed twice by people thinking that they were doing the right things and being like, oh, you didn't share your pronouns. What are your pronouns? And then I either have to lie or I found myself. So always make sure that students know that they have the option to do that, but it's not a requirement. Because sometimes people aren't ready. But yes, so with the age group that I'm working with college students, I think exploration and making sure that students know that it's okay to explore is a good thing. So whether it's their gender identity, their sexual orientation, whatever it is, a lot of our students come in and they feel like they have to know who they are. And it gives them a lot of stress if they don't know, or if something changes about that, they maybe think they were bisexual and they decide that they're in fact a lesbian or something like that. It's okay that those things change. Things change all the time. I didn't know who I was until I was 23, and sometimes I'm still not sure that I know who I am. It's fine. So we'll have students who come in and say, like, I think I'm trans. Can you use this name and these pronouns for me? And we'll be like, yeah, that's what I'm going to do until you tell me otherwise. And then they'll come in a couple weeks later and be like, never mind, that didn't do it for me. And we'll be like, great, fantastic. What would you like to try now? So just the ability to help students embrace that exploration and be like, that's fine. I'll pivot, I'll change until you tell me that whatever it is what you want it to be. That goes a long way for our students. And then I guess the last thing that I want to talk about before I'm done is just that when we work with students who have these needs, and regardless of whether or not they're in the LGBT community, working with students who experience suicide ideation or who maybe attempt suicide is really heavy. It is something that I'm sure a lot of us have done before. I used to work in residence life before I did this, and I actively had to disrupt more suicide attempts than I can count. And it takes a toll on you. So the biggest thing that I want to impart on you all is that when that stuff does happen, you're not supposed to just move on and forget that that happened to you, because it's not an easy thing to deal with. So find a therapist of your own. Find people to talk about. I found Lexapro and I love her. It is okay to need help after working with people who need the level of help that we often will, because your emotions don't go away just because you're helping somebody else with theirs. So that's the biggest thing that I want to say. Does anybody have questions? I'm done. I feel like I just talked a lot really fast.
Thank you, Erin. That was chock full of info. Awesome. Thank you. I want to open it up for questions from the floor, but I do want to ask one question of Bradley first, and I expect maybe others have this question, but it's how do we work to understand our own implicit bias? I know that's not a simple answer, but maybe what can we do like right now to try to understand our own implicit bias?
Well, that's a great question. I mean, first and foremost, you just have to claim that you have it. I think that's the first piece, which is that we all have it. I start off so many of the workshops that I do talking about that I have a complicated relationship with my own racism, my own xenophobia, my own internalized homophobia, my own misogyny, you know, all of those things. And I think it is very valuable. We do things like theater for change, you know, where we do like role playing and scenarios where things come to the forefront. Group work. I mean, I've heard Lucia brought up group work that she does. You know, I think group work can also be so exposing around bias. I think that, you know, I'm not a big fan of organizations and universities and colleges just doing lectures and you check the list off and you say you've done this bias work. I think it has to be experiential and I think it has to be curious. One of the things I know that my colleague and I, Dr. Avula and I do, is we do these ongoing trainings for therapists around implicit bias, and they're 12-week intensive programs, and then they end with marathon sessions on a weekend, whereby we are like almost like a sweat lodge. And I can't tell you how much of my own implicit bias comes out, thinking that I've, you know, sponged all of that was possible. And so it's really important, and Erin is talking about it as well, which is that for us who do this work, is that this is hard. And we are going to screw up and we are going to trip over. And it's all a process of learning more about ourselves and taking care of ourselves so that we can learn more and take care of others. So it's really, I think it's a lifelong process. I claim that my own journey in dealing with my own internalized homophobia is forever. I think we all have to claim that our own journey around potential places of bias and the existing of implicit bias is forever.
Thank you very much. Thank you. Anybody else have questions?
I just wanted to throw a comment out there because
I know you did.
I know, I didn't hear you.
You and me, we always have the questions.
I mean, that's why we started this group, right? We have questions. It's all good. So one of the things is I want to kind of put out there as far as being an ally is engaging in partnership power. And by that, a little bit of an anecdote, my middle child has recently come out to us as non-binary. So we have 13 years to unlearn the pronouns that we previously had for them. And they've given their elder sibling permission to be obnoxiously corrective of anybody within the vicinity when the accidental misgendering happens. And it's absolutely a beautiful thing to see these two siblings working together. I'm getting a lot better about it, but you know, just gonna put that out there. That wasn't a question, it was just a statement. So.
That's a good statement, thank you. All right, anybody else have questions? And Bradley, Lucia, Erin, y'all are free to ask questions of each other as well.
The one caveat I just want to tack on at the end was is that like for a lot of the work that I do, I try not to put the fear of God in the parents of these trans kids that I work with, but like statistics that show that these teens turn to survival sex, eating disorders, substance abuse when they don't have an accepting home environment. I'm not going to say it goes a long way, but it helps to get the gears turning, you know, because it's very important to understand that if we can't have access to these things, whether in the workplace, family, home, in relationship, whatever, school, we do turn to those things to cope because it's hard. It's very difficult, and especially when in the workplace, as was the case for one of my clients, they were suicidal. They were very suicidal for months, and their workplace knew it and did nothing. And so to watch that and watch cases like that that I work with on a frequent basis is just mind-blowing sometimes. So I really appreciate having this panel in this kind of forum to discuss these things because it's so pervasive. And for young queer Black men in the state of Georgia, where we have the highest rate of HIV contraction among that population, like it's not like even the HIV pandemic, a lot of people like to think that's over or that things are getting better because, you know, love wins and we have marriage equality. And the fact of the matter is like implicit bias, explicit bias. We know that these things exist and we're going to perpetually find ourselves questioning if we're safe until we see very substantial changes, not on the macro level, but on the micro level as well, and the meso. So I appreciate having all of this here.
I have
So,
a question for you, Lucia.
what's up?
I was wondering whether or not you ever recommend or find it helpful. We're finding it helpful as parents for our daughter to be in a DBT group.
That's my specialty.
Oh, yeah. And
I
what
love
I'm
DBT.
finding really helpful, and I actually was a co-director at Shepherd Pratt's at Children Adolescent, but
Ooh.
it's so much harder as a parent. I'm finding the DBT parenting group so helpful. Like my husband and I are in a parenting DBT group. So we actually have to do all of the literature that our daughter does. So we have to go through the entire workbook.
Yeah.
I was just wondering if you find that with your client population helpful.
Immensely. Oh my God, yes. I have on the regular 1 or 2 DBT cycles going per quarter. And that's for my adult groups. And then I do family DBT sessions as well, where family members sit down while the kid is learning and they also learn and do the homework that the kid has to do. And so I'm not like Linehan like certified. So I have to say I'm DBT informed. I've been doing it for like 7 years now since I started in mental health. So, and oh my God, the difference that it makes, especially when parents can acknowledge dialectics in their relationships. Like, I don't understand, and I'm still going to do this thing that my kid is asking me, or here's where I am with this. And I know that they're far ahead and I need to do some work on me so that way I can meet them where they're at. It is so unbelievable. Like DBT is like so statistically and empirically supported for a reason. Like it's amazing. Sorry, I
No.
get very excited.
Thank you.
I wanted to ask you guys, what are some good ways that, when we become social workers and we're working with kids or even adults, what are some good ways we can work with them if they tell us they have, parents that aren't accepting or that aren't as accepting as they'd like? Are there certain things we need to keep in mind as we're doing that?
I think that in the work that I do with the parents that I see, validating where the parents are. They're not going to move unless you can validate what they're feeling is okay. And so for me, working with some parents means working with them and they're like, no, I'm not ready to let my kids start HRT. And I'm like, okay, are you going to keep working with me knowing that it is my clinical recommendation and we're going to continue to disagree? Because if we can't have this kind of conversation, there's not going to be a lot of progress that happens. And usually a couple months or even like a year and a half, 2 years down the line, parents come back and they're like, we're ready now. Because the important part is that, like, if you're accessing what at their core is what they're really working with, which is, I want to protect my child. And if you can validate that and reach that core with them, that is very important. And for the kid, like whatever that age is, that kiddo is, helping them to find the ways that they can transition until they can either make their own medical decisions or parents start to make the more informed or more gender affirming medical decisions with the kiddo. So the coping skills that I usually emphasize to ameliorate things like kids reaching for substances, for eating disorders, self-harm, any of these things that my kids usually struggle with. And I will continue to say, like, hey, listen, they say that this is the thing that they want. They want a binder, they want hormones, they want to be able to cut their hair. Finding where parents can validate that and start to find the wiggle room is really important. And when the parents see that, like, my kid is continuing to insert ineffective coping skills here that I don't want to name specifically because I don't want to trigger anyone, right? When they see that these things continue to happen, despite all their interventions, they're usually pretty amenable at that point to, oh, the thing that my kid was always telling me they needed, now I'm ready to do it.
Heather Lane?
can I clarify on that one? So it sounds like you're saying making sure that you can decouple the tie between the gender affirming care and what other issues might that kiddo, I love that wording, by the way, might be going through. Is that correct?
Yes, yes,
Okay.
absolutely.
Thank you.
I'm curious, is there an age that kids have to be before they start hormone replacement therapy?
No,
No.
not at
Okay.
all. I refer to Dr. Leo at QueerMed for all of the kiddos that I work with. And he says, as soon as they start having questions, send them his way. Because at the very least, maybe they're appropriate for blockers, but not yet hormone therapy. And hormone blockers are great for like setting off puberty, which can be a really triggering time for a trans youth. So as soon as any of my kiddos ever have questions, I put them in contact with Dr. Leo at QMed. And I've not yet heard any negative reviews for Dr. Leo. He used to work at Emory. Now he works in an entirely trans practice. And all of the families that I've referred to him at Emory stayed with him when he made that transfer, because the care that he provides is profound.
Okay. Any other questions? All right. Well, thank you, Bradley, Lucia, Erin, and everybody else who came. I know I learned a lot, and I hope you guys did too. So just want to thank you for coming and teaching us. And we'll keep learning. So
Absolutely. Thank you for having me.
Thank you
All
so
right.
much for having me. Appreciate it.
Bye.
all right. Bye-bye, everybody.